right, it looks like it's that time. It's 7:30 sharp on the dot. So I'd like to welcome everyone and thank them for joining. We're going to start off with some CMN details and housekeeping before we dive into the amazing presentations we have this morning. Firstly, I would like to start off with a land acknowledgement. We would like to recognize that although we are webcasting from and to many different parts of Alberta today, the province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory, and that this is a meeting ground and home for many different Indigenous peoples. So thanks to the engagement of our scientific planning committee, I see many of faces on the call this morning. A big shout out to them and for their diligence, creativity, and input when it came to putting together this session. We decided it would be really great to have short, impactful, really valuable sort of short snapper sessions to kick off our first September session. So that's what we're coining this, is our back to school short snappers. The three topics we're going to be covering this morning are pregnancy and polysubstance use, street drugs 101, and 3 things this pain patient wants you to know. So again, big thank you to our presenters for putting this material together. We're very excited to bring this valuable content to you guys. Again, all of these slides will be shared with you after the fact, so no need to be harried or take notes. We'll make sure you get all the material that you need. All right, people are joining us by the minute. So I'd like to introduce our medical lead, Dr. Kathy Scrimshaw, and to give her disclosure, please.
Had to unmute. I'm Kathy Scrimshaw, and I'm a part-time employee of the Alberta College of Family Physicians. Otherwise, I have no conflicts of interest.
Excellent. Thank you so much, Kathy. On to myself, the voice that you hear in the background oftentimes, Carrie McNabb. I am a full-time and paid employee of the Alberta College of Family Physicians. And next, we have a new name to introduce you to. So we are very excited that with the expansion of the CMN, we're able to gain new coordination and staff support. And this is in the form of Agatha Grachowski. Agatha, would you please unmute, introduce yourself, and give your disclosure, please?
Hi, everybody. My name's Agatha Grachowski. I've been working at the Alberta College of Family Physicians just over a month now, and I'm the coordinator of communications and technology and work mostly with the CMN. So that's my disclosure, and it's nice to meet everybody.
Thank you so much. We are so excited to have Agatha on board, and she's the one responsible for the fancy new CMN logo and slide template that you're seeing today. So all of that creativity comes from her, and we're very excited to go forward. Our disclosure of financial support, we were actually recently received a funding contribution from Health Canada's Substance Use and Addiction Program. So this funding will support us over the next 3 years. We also received financial and in-kind program support from the Alberta College of Family Physicians. Again, this is credited. So for family physicians, this is available for CME credits. I am tongue-tied this morning. Each session is available for 1 credit. So we do have a Survey Monkey link in the chat log. So if you could please click on that link at some point during the session this morning, enter your first name, last name, and email address. That's how we're going to track attendance and make sure you get your certificate of attendance. We typically do them at the end of the year. You'll get your certificates for September, October, November, and then we'll split that into the first half of next year for your certificate. Big news. With new funding and new expansion of including our primary care team members, we have some work to do. So the CMN has engaged 3Hive, which is an evaluation contractor. They're actually very experienced when it comes to working with primary care. And we're so excited to work with these people and really focus on data-driven improvements to the CMN. So focusing on how we can improve, what impacts we're making, what ways we can serve our members best, all of that great stuff. But it's really crucial for us to get a baseline right now. So before we're able to make a lot of improvements, to really see where our members are at, what they want, what does our membership base look like. So if I could please urge everyone on the survey, or everyone on the call this morning rather, to please do this survey. It is really quite short. It helps us in a huge way to give us a really great picture of where we're at with the CMN right now. We do have a quite quick turnaround time. The survey is going to close next Thursday, October 1st. So this will be sent out to you guys via email as well, but just a little plug here to say, please, if you could fill this out, we would be so appreciative. Any questions around this survey or anything like that? All right, I'm just going to take a quick peek at the chat log. As Kathy has pointed to, there's a new Alberta opioid report. So she's posted the link into the chat. So that's there for reference. Kathy, did you want to speak to that at all quickly?
I think probably everyone saw it in the news, but it's a bit of a grim story. And I just wanted to make sure that people had access to the report, but we've got a marked increase in opioid related deaths. And we'll be working on that issue over the next year and seeing what we can do as primary care to improve that.
Sorry guys, struggling to unmute myself this morning. Perfect. And moving on, this is our agenda for this morning. Honestly, we've got a lot of great content and we're packing it into 10 minutes. We know you want a lot in a little time, so that's what we're aiming to deliver. So very excited to have presentations from Janetta, Monty, Rachel, and Ryan this morning. So as we go through their presentations, they'll give themselves a little introduction and then they'll dive into their material. Please feel free to post questions in the chat box as we go along. I think some presenters will answer as they go through, but what we've typically decided is we'll try to get through the content in about 10 minutes and then wrap up with about 5 minutes of Q&A per person. We'll do our best. We don't like to run over, so we'll do as much as we can. And again, we will get those slides to you after the fact, so that material is all yours. So our first presentation today is Pregnancy and Polysubstance Use by Janetta. Janetta, I do have your slides at the go, but if you prefer to share and change them when you like, I'm happy to turn over screen sharing to you. I will give a tip that if you guys, if there's a particular presenter, you can go into participants and spotlight their video so you can see that particular presenter, which might be quite nice for you guys.
Carrie, it's fine for you to advance if that's okay, just so we don't.
Got it.
I mean, I think it'll just flow better at your end, so.
No problem. I will go whenever you cue.
All right, so thank you very much for inviting me. I'm a family physician, a health services researcher. I have interest in patient engagement, social accountability work, and on the side, I deliver babies. So I find myself at the intersection of addiction and obstetrics quite often. So I guess that's why I got picked for this one. I do need to just acknowledge and tip my hat to my lovely colleagues at the Grey Nuns, both Janine Wismark and Kathy Cardinal, who have spearheaded a lot of the in-hospital stuff that we've been doing for women who use drugs, and certainly have informed this content. I am one of their colleagues, but I can't say that I was the one to really spearhead the implementation of what we're doing there. So I do have my hats off to them. I do have some disclosures. I have no pharma or industry relations, but I do receive peer-reviewed grants, grant funding, or have recently from CIHR, NACTRAC, the Royal Alex Hospital Foundation, Inner City Health Associates in Toronto, and Alberta Innovates. I have received honoraria and or modest remuneration for expenses to travel to present on, from the ACFP, the SOGC, the Alberta College of Pharmacists, and the Canadian Foundation for Healthcare Improvement. And I am the secretary on the board of directors for AWARE, our provincial chapter of people who use drugs. So you can advance, Carrie. So what I'm hoping to cover with you in 10 short minutes, I'm going to focus on not on alcohol, tobacco, and cannabis. Not that those things are not important, but as I indicated to Carrie this week, if you could please just enter into your chat resources that you would like to see, because I will curate a list of resources that are relevant to your practice, because I don't know how many of you are giving interpartum care. I don't know how many of you haven't seen the recent infographics and so on from, for example, CCSA around cannabis and pregnancy, alcohol and pregnancy, but I'm happy to share those resources if you need them. What I was going to focus on is more just common stuff that comes with substance use. And I'm using the word illegal here. I know some people will use illicit. I like to push it back to illegal, because it really licit or illicit implies that it's with the woman, as opposed to the drug policy that decides what's sanctioned and what isn't. So I feel pretty strongly about that. So I'm just going to focus on more opioids and stimulants today, but it's not to say that the other substances aren't also important. I'm going to talk a lot about intersectional harm reduction and trauma-informed approaches for caring for pregnant people who use drugs as well. And I will caution, there was a recent CMAJ article around pregnant people as opposed to always thinking about pregnant women. So I will have a case today where the patient identifies as she, her, but remember that not everybody will identify female who happens to be pregnant. So just bear that in mind. Next slide, please. So Sam is a 25-year-old G3 P0. So she's had a couple of miscarriages in the past. She's presenting at 28 weeks with irregular cramping. She's had very little prenatal care. She had an emergency department visit for constipation at 22 weeks and happened to have an ultrasound at that time. And so we have an anatomic ultrasound, but not much more. When asked in a non-judgmental manner, so we can get into that if you want, Sam discloses that she has been using some oxycodone, about 140 milligrams morphine equivalent daily, give or take, though it's variable, and that's an important piece of information. She says that she has not been injecting and is limited to other routes of ingestion. She acquires her pills primarily from friends as opposed to prescriptions, so there's really no pharmacy trail on her. There's occasional cannabis use as well, not every day, but she does smoke 5 to 6 cigarettes daily, no alcohol or other substances currently, although earlier in the pregnancy she has used meth. All right, next slide. So, but the social history is just as important. So Sam holds a part-time job. It's barely paying for her expenses. She does have mounting debt. She lives with a roommate and there is no partner involved. So I think she's managing rent at this point, but not tons more. Nutrition is an issue. Past medical history, anxiety and headaches, that's it. So you do the physical exam, and of course, this is the first place where I have to just park and say, remember, as a team, it may not even be explicit bias, but we may have implicit bias, particularly against pregnant people who use drugs. There's plenty of blaming and shaming of people who use drugs in particular, but the pregnant person is one that tends to get a large brunt of it. We also tend to even implicitly put our blinders on and assume that everything that we see as far as symptoms is related to drug use, but it may or may not be. So just be very aware that someone in this situation may be presenting with an abruption. That's if someone's, twitching a little bit, it might be preeclampsia. It might not be related to substances. So remember to cast a wide net and use your diagnostic acumen and think about your differential diagnosis. It is absolutely critical to avoid a bad outcome. So vital signs are stable, normal level consciousness. Her symphysis fundal height is consistent with a roughly 28-week gestation. You've ruled out progressive cervical dilation shortening or an active infection. We don't think she's sprommed either. Her abdomen is soft and non-tender. We've got normal uterine tone. As you know, sometimes those of you who do interpartum work, you're not going to have much in the way of a fetal monitor electronically at this point, but it looks okay for gestation. She doesn't appear to be actively intoxicated or in major withdrawal at this point in time based on physical signs. Next slide, please. So I just kind of put that out there as this is a presentation I've seen, or a composite of many presentations. It's certainly common enough stuff. So substance use in women, the key things here are that we, unfortunately, our society often thinks about substance use and thinks about male gender, but remember that that gender gap is shrinking, and that the disparity in prevalence rates is not as prominent as it used to be, and that women are generally more vulnerable to the adverse health effects of most drugs, most psychoactive drugs. The other thing that's really important to think about when we're talking about gender and substance use is the other intersections that matter. So remember that in pregnancy, for example, violence gets ratcheted up. So thinking about intimate partner violence, but also just violence more generally. Racialization and colonization may be present, and women tend to experience this in a unique, particularly destructive way. Think about low socioeconomic position. I alluded to Sam's possible food insecurity earlier. And think about mental illness as well. Next slide. So all that being said, I said don't get your blinders on and assume everything is related to the substance. However, based on primarily observational data, we do know that opioids tend to lead to, sorry, I shouldn't say lead, are associated with fluctuations in fertility. So you may have more unplanned pregnancies because of variable use, but you'll also have more amenorrhea. An increased rate of low birth weight, intrauterine growth restriction. There may be possible changes to your electronic fetal monitoring, to your biophysical profiles. So those practice breathing movements that we see may not be as frequent. Variability tends to be a little bit more less prominent with the fetal heart monitoring. Abrupt cessation is associated with uterine irritability and on occasion premature labor. So we will see a lot of women come in at 35, 36 weeks rather than term. Next slide, please. On the stimulant side, and although she says that she wasn't using meth currently, you just have to be mindful that it's a back and forth when we're talking about use. So you want to be vigilant and just check in and see if she's needing to use again. So increased blood pressure, premature labor, we do see again the growth restriction patterns. Abruption is more common. The fetal effects are, it's a little more tenuous. We don't have a ton of data. There may be an increased risk of cerebral infarct and some genitourinary stuff. But again, those associations are more tenuous. As far as, I'm just going to talk a bit about management here because Sam is not actively using, but remember that the withdrawal syndrome here is primarily psychological, and if there's plenty of support in place, you can discontinue things more quickly. And I wanted to just mention here that I use a women-centered approach to what we, what do we do first? And it can be daunting. Pregnancy is a very motivating time to make changes to substance use, and most women are very interested in doing so. But it's rather daunting to think about stopping everything cold turkey, and in some cases might actually be dangerous, for example, in the case of opioids. So I usually ask women what they want to focus on first and explore the effects of a variety of substances and figure out why someone's using. For example, when it comes to stimulants, someone might be suppressing her appetite because of food insecurity, or she might be scared of violence and need to be hypervigilant, or there may actually be housing insecurity and she's just trying to stay warm at night. So there's a variety of reasons to use. Maybe she's falling behind in school and has to stay up all night to finish her studies. So there's a lot of different reasons to use. So starting to explore that and trying to eliminate those barriers and figuring out which substance to focus on first. That's with some guidance from the physician as to what direction we might take. So I try to focus on one thing at a time. Talk a little bit about breastfeeding for stimulants. And usually if you can get someone to start pumping supply, if there's intermittent use, I'll sometimes encourage them to just bottle if they're going through bottle and have some other support from other responsible parents if they're going through a period of temporary lapse. The last thing, which is very important, I think many of you know this if you care for people who use drugs, that in Western Canada, contaminated supply is the rule right now. So we had some data on this, that most people who use meth haven't been assessed for overdose risk, and yet have experienced overdoses and don't have a naloxone kit. So think about that when you're counseling people who use drugs or who use primarily stimulants. Next slide. So trauma-informed care practice, I like this. This is from Dr. Cardinal, and so she's in my head here. Practice universal precautions when it comes to trauma. Assume that everyone has trauma. Act accordingly. Have a safe and welcoming environment. Use language that is woman-centered. A woman who uses drugs, a person who uses, not addict, not you know, there's some words that are better than others. Use consent. Take more time for consent. Remember that there may very well be sexual trauma and that we're talking about a reproductive space. So be very aware of that. Okay, lots of shared decision making. Next slide. Harm reduction. So there are some associations between harm reduction and the obstetrical patients. So talking a lot about reduction of high risk activities such as sex work and so on. Reduction of infectious diseases associated with higher risk activities. This should be important to those of you who practice in Alberta, because we have seen syphilis on the rise, for example, perinatal syphilis. We do know that harm reduction works on relationship building in the pregnancy, and there's a decreased need for child and infant apprehension as well. Next slide. I just want to remind folks to think a little bit, and we talked about this earlier, think a little bit about the unique things that come with drug use during pregnancy. Think about safety, think about nutrition, think about STD/BI prevention, because certainly that is going to complicate the pregnancy as well. A lot about the partners, who's going to be there is that labor support person. Is there somebody who's going to be there for that woman? What about her kids? Is there someone who can look after, who can help her so she can have a good pregnancy and a good birth? How isolated is she? Does she have access to prenatal education and supports? Next slide. So as far as treatment specifically for opioid use, so stabilize the use first. That's the main thing. And if a woman is open to it, certainly we can use standard opioid agonist therapy, and our many of you may be prescribing to non-pregnant people but may not have a lot of experience with pregnant people, and certainly if you feel like you need some mentorship or the involvement of an addiction medicine specialty team, these folks are going to be prioritized accordingly. On occasion, a woman just wants abstinence. You have to have a cogent benefit versus risk discussion about that. If you're going to be explore that, the ideal timing is in the second trimester, because we start to see change in opioid receptors in the third trimester, and it gets a little bit trickier to attempt to taper down at that point in time. We're also trying, as I mentioned before, trying to avoid preterm labor from an inadvertently rapid withdrawal of opioids. So we talk about very slow tapers if we're going to be taper at all, and we understand that there is a risk of relapse and with that overdose if we go that route. So no need to stop if someone's, we've managed women with chronic pain on opioids in our obstetrical practice, and there's certainly no need to stop or change therapy for those women. And on occasion, we do need to do some dose adjustments again because of receptor regulation. Next slide. So just a word on counseling and what you can do. So I focus on where someone's at, whether they think a change in substance use is feasible at this time. So I talk a lot about how important is this particular substance to you, how important is it to you to change the amount you're using, and how ready are you feeling. So just a reminder about all of that. And I do talk a little bit about a lot about what the barriers are. As far as contingency management, some of you may be familiar for that and with that, and it's a very formalized approach, particularly with stimulant use, about rewards, focusing less on punishment but more on rewards. So hey, congratulations, you know, you've had a urine that's negative for non-prescribed substances this month. Here is a in the formal studies, here's a modest cash reward. So, but the thing is, that's often outside of scope of a family practice setting, and sometimes it doesn't have to be full abstinence. So I focus on any positive change, and I do talk about rewards, smaller rewards. I've had some people who really all they would like is to have a nice notebook or something like that, and I might say, hey, what's the change that you want to see this month, or what do you want to maintain? Well, someone might say, you know what, I got my use down to once a week. That's awesome. Okay, so if we've got that, then okay, what's the reward going to be? So I'm abstinence doesn't have to be your only goal, and I do mention contingency management here just to highlight that sometimes focusing on rewards and what's going well is more helpful than punishment. All right, next slide. Treat pain. I'm going overboard, so I'm going to wrap up here. So treat pain intrapartum. Baseline dose plus additional analgesia for pain. Okay, keep that in mind. We do have access to epidurals. They can be quite helpful rather than PRN opioids, just to stabilize things. Remember that you may need a baseline dose reduction postpartum, again, because of receptor regulation. Next slide. Newborn care. So some of you may be familiar with what they're doing out at First Square at BC Women's. We're doing a similar model at the Grey Nuns, and there's a few more hospitals starting this up. So just the idea of rooming in with the baby, plenty of skin to skin, a quiet place, a few lights, that tends to reduce the experience of neonatal abstinence syndrome considerably, and very few of our kiddos have had to be transferred to the NICU for morphine, etc. Most of them can stay with their mom and typically another support person, and then their extended stays. All right, and then I would say with that, just invoke your whole team, start discharge planning early, talk to the community-based provider if you happen to be covering for that person in hospital, because you definitely don't want to be sending that woman home on Sunday without a prescription, etc. And you definitely need to have a social work plan, just an evaluation of the situation. Some of you may be wondering about Finnegan scores and whether we're still using them. We're increasingly moving to something called Eat, Sleep, Console. It's more straightforward, and we look at that Eat, Sleep, Console scale as well as weight gain, whether a baby's feeding and growing. And those seem to be just as good an indicator as the Finnegan, if not better. So that's all I've got on newborn care. Any questions?
All right, so Janetta, I will say thank you so much for this presentation. This has been fantastic. I've seen some questions come into the chat. Due to time, and I do know that you need to go, we will take all the questions that are posted in the chat log, and we can follow up with you, as well as with those requests for resources and references. And maybe we can continue the discussion on the discussion board.
That's great, thank you. And so I will curate that, and I'll be happy to answer questions offline, and thanks.
Awesome. Thank you so much, Janetta. We really appreciate it. Have a great day. Thank you. All right. So in the interest of time, we again apologize for rushing, and thank you so much for Janetta and her fantastic presentation. We are going to now segue into our second presentation of the morning, which is going to be done by Monty and Rachel. I'd also like to give a little shout out to Monty and Rachel, who we've recently formed a scientific planning committee, and both Monty and Rachel have agreed to be a part of this. I'd love it if you guys would unmute and give yourselves a little introduction. I've got your COI slides ready to go, and you can either share your own screen or cue me to change whenever you're ready.
I think I'll just cue you to change if that's okay.
You got it.
Easier. Okay, so I'm Rachel. I'm a registered nurse. I have worked in this Treaty 7 territory for the last 12 years with vulnerable populations, mostly in harm reduction. Perfect, thank you. the only disclosure I have is really that I'm the co-founder of Westside Harm Reduction. Monty, do you want to introduce yourself?
Yeah, hi, I'm Monty. I'm a physician in both Treaty 6 and 7 territory. I forgot to do my disclosure slide, but I have some grants from CIHR Alberta Innovates. I don't have any speaker honorariums and no other disclosures to share.
Awesome, thank you.
Next slide, please. So just for sake of time, we're just going to chat really quickly about a couple of the, or a few of the most common substances that we might see. But I really would love to hear from everybody. We do have 10 to 15 minutes of time here. And so I'd like to make sure that we answer any questions that you have, reminding people that this is a safe place. Any dumb question that you ever thought to ask, please throw it out there. We will try our very best to answer it. Yeah, so just chime in, unmute yourself if you have a burning question you just want to know before we even get started. And that can maybe help guide our presentation, because we could literally go on for 4 hours about this.
And one thing just to say though is, at least for my portion of the presentation, there's a lot of the stuff is anecdotal and just information based off people of lived experience. And ideally someone of lived experience would be giving this presentation.
Yeah, absolutely.
But you got us instead.
Yeah, sorry about that. Okay. So I mean, most of you guys know what an opiate is, and you've all seen that lovely, finally we got our Q2 report out. And so really 2.5 people are dying every day from opiate overdose, which is problematic in our province. I think that there were some assumptions pre-COVID that the drug supply would be altered in some way. We didn't quite know what that would look like. Here in Alberta, we don't do a great job of testing our substances. And so the data that we have is from BC mostly. And so pre-COVID, the fentanyl that was bought on the street tended to have about an 8% concentration of fentanyl or fentanyl analogs in it. And now we're seeing in BC again, this is not Alberta data, but in BC again, about a 24% concentration of the fentanyl and the analogs that are found in street substances. So that's really problematic. Certainly it's changed the way drugs are getting into the country with our borders being closed. And so it has drastically altered the concentration of the supply, but also the way people access the supply and how expensive it is. And also the quality of the substances are just so unpredictable, very impure, mixed with all sorts of additives that are really quite problematic, including benzodiazepine. So we're seeing high concentrations of benzos in the drugs that are bought on the street. And so we're seeing some really strange overdose responses because people maybe we're not noting that respiratory depression, but we are noting this, very altered level of consciousness related to the benzodiazepines, and it lasts a lot longer and does not respond to the Narcan as we would expect an opiate to respond. So certainly a much more volatile market of opiates right now on the street. Just for curiosity's sake, I thought I would find out how much it costs, because people often ask that. And it really is helpful when we're talking to patients in those lower socioeconomic groups. If they are dependent on a medication and they're buying it at the street level, how much of their budget actually has to go to that, right? So right now, a point of heroin or down, really there is no heroin. I don't know why I said that. There's no heroin really on the streets right now. But a point of down would cost about $20 if you have an established connection with a known dealer. If you don't and you go to somebody brand new, they're more likely to charge you $30 or $40 for a point, which again is 0.1 of a gram of heroin. And so keeping in mind that people with fentanyl and how quickly it is metabolized, people are needing to inject, usually a minimum of 4 times, but more like 6 or 8 times in a day. And so that can be quite expensive, and often they're injecting more or smoking more than a point at a time. So something to keep in mind when you're budgeting or planning with your clients.
Mhm.
Monty, did you have anything to add?
Yeah, so one thing to note is that the price of down has stayed the same pre-COVID to post-COVID. So you know now that people are mixing other stuff in to keep the price down. So we're seeing higher concentrations of fentanyl for that reason. As Rachel mentioned, there's like tons of different fentanyl analogs out there, and there's benzos that are being mixed with fentanyl. So you got to be careful. In terms of the colors that we see in the streets right now, like
Oh, yeah.
this right now shows black fentanyl, which is what we used to see with pills maybe 2 or 3 years ago, and they're changing colors constantly. So you can't really go and rely by color, because clients will tell you that they had a purple or a magenta color of fentanyl the other time, or now it's green and blue.
Yeah.
You can't go by color anymore. You can't predict what the effects are going to be or how long the effects are going to last.
No.
One thing you can do is have an naloxone kit nearby, as that's your best antidote, or use in a supervised consumption setting. Or supervised setting.
And often last week there was, in Calgary anyways, there was between the 17th and the 19th of September, there was an increase in EMS calls to one particular area. And so again, likely when we're looking at those networks of people who are using drugs, there was a batch that was causing an exponentially large incidence of overdose and adverse responses to that medication. And Monty is totally right with the substances that we see. The color is constantly changing. It might be purple when you buy it in kind of a rock or crystal form, and then when it cooks up, it's a beautiful blue color. And so often that's how we warn people, like, hey, you know, if that's blue, just make note. You know, people have been going down really hard with that. So the other thing we're not seeing is pills. They're not even there. Nobody's really taking the time to use a pill press anymore. That really is just sort of an added step that we are not seeing on the street.
The thing I want to add though too is that because of the dilution effects and because it's only $20 a point, sometimes what you'll have is you'll find clients say that they're actually not getting the effect that they want from the usual dose because it's been diluted with, like, say, detergent and other things like that, for example. But then the next batch that they get, it's overly concentrated. So you just got to really warn patients that the supply is fluctuating. It fluctuated before in terms of its purity, but it's even more so now post-COVID.
Which is especially, you know, we often think of people mostly injecting their opiates, and really that's not the case. That's the demographic of people certainly who are using the consumption site, and only because we don't have an inhalation component in any of our consumption sites now that Arches is closed, and the majority of people are smoking their opiates. So I think we should move to the next slide. Thank you. Oh, you guys already know this. That's what heroin might look like, although we've kind of just talked about it. Very rainbow of beautiful colors right now. Next slide, please. Monty, do you want to chat about this one?
Yeah, so this is from the latest opioid report. One of the big things I want to point out is the rise of carfentanil. As you can see, carfentanil was always around, but in this last quarter, there's been a huge jump, and it's mostly in Edmonton, as opposed to Calgary. Again, showing that there's a difference in terms of what drugs are being used and shipped and shared in certain communities. Of note, there's over 1,500 analogs of fentanyl that are out there. Only 250 of them are actually studied. And these are the ones that are reported from Health Canada. And they have different lengths of activity, different half-lives. It's hard to predict, but they're still all very, very potent drugs. And just want to acknowledge that. And so just, yeah, again, the drug supply is ever shifting. We're seeing different types of drugs that are coming out. And carfentanil is definitely on the rise.
And that is certainly reflected across the country and in Alberta specifically, where 301 people have died in 3 months in those Q2 data. So really, you know, we are noticing that. We are seeing the impacts of that. Absolutely. Next slide, please. So we'll chat very quickly about stimulants. Next slide, please. I am currently drinking my morning stimulant, and that is helping me get through the start of this day. Next slide. I'm pretty sure you guys know this. Cocaine is really not something that we see a lot of in that lower socioeconomic group. Certainly, many of you may see this in your practice. The reality of this, though, is that we may not always know who is using this without those drug tests. It tends to be in sort of the SES setting. It would tend to be something that is injected, but certainly people can smoke it as well. Next slide, please, unless you want to add anything about cocaine.
Yep.
Awesome. So crystal meth really is a big problem. And I often joke that we should bring back crack because the adverse effects and the behaviors associated with it, with crack versus crystal meth, are just a little bit more manageable in the setting of homelessness and shelter settings and that sort of thing. Crystal meth is used pretty often in those settings because it lasts a really long time. It's relatively cheap. So 1 point of crystal meth would cost about $10 right now, unless you have, and when you have a good connection. If you don't have a good connection, you might be charged 15 to 20 for a point, again, so 0.1 of a gram. And again, most people are using more than 1 point at a time. Anecdotally, it is very hard to get and find crystal meth on the streets right now. People just are not able to find it, and they are not experiencing the same effect that they're looking for. When they do find it, it is often laced with opiates or benzos, so people are not expecting that. They're expecting that stimulant response and are experiencing an opiate-like response, which is really problematic, especially if they are opiate naive and there's opiates in there. They're much more likely to experience an overdose. Next slide, please.
Can I add a couple bits to
Oh,
this?
yes, please.
Yeah, so I mean, the reason why meth is so much more popular right now is because the price of cocaine is about $100 a gram. So it's quite expensive to use compared to crystal meth, which is a lot cheaper. As Rachel mentioned, there's a lot of tainting. Prior to COVID, I would say, like the clients that I spoke to, they would say about 1 in 10 times they'd have the nod when they're using crystal meth, alluding to what Rachel mentioned about opioids being laced. I'm sure that number is higher now, post-COVID.
Mm-hmm. And Laura, I just saw your comment. Certainly, lots of people are using cocaine. In my practice, in the settings that I've worked with, I don't see a lot of it just because of that expense. Next slide, please. Wanti, do you want to chat about this?
Yeah, so just a quick overview of how quickly the onset of these drugs can occur, especially with crystal meth. And these are similar numbers for cocaine as well. So orally, if you smoke it, or if you take it, I should say orally, it's 20 to 30 minutes. Nasally, it's 3 to 5 minutes. Intravenously, it's within seconds. Inhaled is also within seconds, and rectally is a few minutes as well. So, I mean, this is really important just in terms of when to expect certain effects of certain drugs. What's interesting, though, is that if you do inject it within seconds, you get the dopamine release within seconds as well. But the physiological effects can happen anywhere from 10 to 15 minutes afterwards. So yeah, just something to note.
And again, depending on the concentrations, you know, in the setting of supervised consumption, we are seeing people literally go down before the syringe is out of their arm in that setting. And so, you know, that 15 to 30 seconds is in real time quite alarming. And certainly, again, we have people that are inhaling their substances outside of the SCS and going down outside the SCS quite often. But all the other routes we pretty much do see in the setting of SCS. Next slide, please. Do you want to talk about these, Monty?
Yeah, sorry. Yeah, so like, I mean, just something just to be a note of that there's also CNS depressants that are being used out there. So these are benzos, illegal benzos are being mixed in with a bunch of stuff. With a lot of our drug supply, other drugs of misuse can be things such as Z drugs. So we're looking at zopiclone can be one as well. So I always try to get people off the zopiclone if I'm dealing with certain concerns. The reason for that is zopiclone and other Z drugs actually work on the same alcohol receptor, or same receptors as alcohol does, but a different subunit of it. usually just works on one fixed subunit as opposed to the 5 subunits that it typically works or that alcohol works on in the GABAergic system. So just an FYI, let's keep moving.
Yeah, I think we can skip over some of these slides: sedatives and hypnotics, anesthetics. Again, sometimes these things are mixed in with many of the substances that we see on the street. So just to note that, lots of benzos in pretty much everything. Next slide, please. Actually, benzos in the substances is something to make note of, because when we're talking about withdrawal symptoms and syndromes, often we sort of dismiss the fact that there may be benzos and there may be a component of benzodiazepine withdrawal within those opiate withdrawal symptoms. So something to note. Next slide. And next slide. I think you guys are pretty good with this. I think we can probably end here and just answer questions. There was a comment about what crystal meth is called in Edmonton. Super interesting. Sometimes they do the name of the drug. People don't just say crystal meth, they'll say they use side, or they'll use a speedball, which is any opiate and any stimulant. But you guys probably know that. Are there any questions? Sorry, that was so rushed today.
No worries.
That was really rushed. We can talk about like stuff like ketamine later on too, like Special K and whatnot. And
Absolutely. Thank you both so much. I know that was definitely a challenge getting as much information in as we can. So thank you again for sharing your slides. We really appreciate it. We'll make sure that everyone gets that. And again, if you guys, if there's any questions that come to you after, you can always email us at mentorship@acfp.ca, and we can always track down the answers to your questions if they come to you a little bit later. So anyways, a big shout out to both Rachel and Monty. We really appreciate your presentation this morning, and we are on to our third and final presentation of the morning. I would like to introduce another new member of our scientific planning committee. His name is Ryan Magnuson. Ryan, if you'd like to unmute yourself, introduce yourself a little bit, and describe your presentation this morning.
Yeah, good morning, everybody. I am Ryan Magnuson, like I said. I've been disabled since 2004, and I do part-time advising with Alberta Health Services as a patient advisor. Mainly the Connect Care project, and then most recently in the opioid and chronic pain areas. I'm 58 years old. I've basically had pain since 10. I ripped off my finger when I was 9, and I was diagnosed with ankylosing spondylitis when I was 13, and we carried on from there. It of course didn't affect things till later in life. I forgot to disclose. No associations or conflicts. I'm just going to go through some things that popped out to me quickly when I got asked to do this. Just the first time prior to ever having any pain or narcotics or issues. Like I was a crazy sports guy from 16 till 36. I didn't go to doctors, and I hurt myself 1,000 times and stuff. Anyway, I went to the hospital with neck pain one night, and I had no idea of what it was. The pain, it was muscle, nerve pain. They couldn't really decide what it was. So the doctor there plainly said, "I believe you're in here because you want to get the drugs." And I'm like, "I don't know what the drugs are. I've never taken them. I don't need them, this and that." And they were, next, if we can, very vocal about the situation and stuff. And it's just a stigma. I was quite disappointed that that's how they presented in the beginning, because like I said, I had no notion, and it being treated as if I was a drug person all the time. Next screen, if possible, Carrie. All patients are different, unique, and you don't understand, especially pain. It's hard to describe and get across what's causing the pain. But the biggest thing is people are in pain, not necessarily looking for drugs. I know that you get a lot of that, but I would like to see it, that patients get the benefit of the doubt, I guess, first, before they just assume that they're using the drugs. Next one. Okay. One of the things that sort of always got me is the perception of pain. The pain that you see, it's dependent on their perception and expression. we always go with the 1 to 10 score, which is very good and effective. But I've always wondered if there's a way we could measure pain that people have, compare it to other pain, you know, and see how it fits into that. I don't know what research goes on around that type of things, but, you know, everybody feels it different, expresses it different, and length of time with pain, living with pain, no pain, medications, etc. So we run into a situation where you can be like, for me, I can be in a 10 pain. And if it's not the jabbing, skilling, I call it screamer pain, then it's the deep, dull pain inside the body. Well, I won't look like I'm screaming and I'm not in pain, but I am in a 10 pain. I've got thousands of stories to tell you, but I fell, broke my neck, and the paramedics didn't believe I was seriously injured, walked me out without a collar and stuff. And they couldn't see. I mean, if you looked at my medication list, I'd just taken 45 milligrams of hydromorph. I had just smoked a little bit before that. You know, I shouldn't be in 10 pain, although they couldn't find the mechanism that might have indicated an injury. And the doctor was sort of the same at the hospital until they did the x-ray and found out it was a fracture of C2. And then things just went crazy and they was treated so much different. It was amazing, right? But so pain from each patient, you got to know them and their pain in order to be able to judge it and manage it properly, I guess. Next one. Mental health and chronic pain. Things for patients, I guess, you know, is it ever going to get easier to live with? Will the pain ever stop? Now, I know for severe chronic patients like me, it's never going to stop, but you always want to know if it's going to get easier to live with. And it's a very difficult thing to live with all your life, right? And for sure, if you have chronic pain patients and severe chronic pain patients, you need to focus on their mental health throughout their time, because they're going to have mental health problems, but they're not going to want to maybe talk about it, right? I was that way. I didn't want to, I avoided mental health issues. I didn't believe, you know, I had the stigma, antidepressants and stuff. And my sister's a nurse and she finally convinced me that yes, they do work. You may have to try a few over time to find the one that works and this and that. And it did, it helped a lot. Now, I don't seem to have much mental health problems except the suicide issue, which pops up unwanted periodically. The reason I say that is I don't believe in it. Suicide generally is okay for, I guess, the person, but it leaves people hurt on earth. It really doesn't make a great solution. And if it's a doctor-assisted type thing, I totally agree with that. But the stigmas, I mean, also there's the stigmas that go along with the mental health that people don't want to admit they have any little problems. And then that same stigma then goes down to medications, the narcotics and the antidepressants. If people know you're on them, they tend to think one way or another. And really they don't know much about it themselves, and they're just guessing on what they're sort of experiencing or seeing. And next one. Okay, this is my good one. Opioid treatment discussion. It's a life-altering decision, the biggest decision of your life as a patient. Requires discussion, education, careful thought. The care plan will be constantly reviewed with the primary care physician and periodic reviews of the pain specialist. The biggest thing, you know, people, I was one, I didn't want to get involved with them at all. I didn't, you know, all my life wanted nothing to do with hard drugs or addiction things. And you have to, you know, in initiating this discussion of narcotic treatment, my doctor brought out the things of quality of life versus length of life decision. Now I was the president CEO of one of the fastest growing businesses, coaching hockey, very active. Like my hours, I slept 4 to 6 hours averagely. I had a very active, super busy life, a lot of athletics, a lot of injuries. And my doctor was 40-ish, basically said, you know, you can have 10 years of life with good quality of life or 20 years of life with no quality of life. And so I had to really weigh that. Kids were like, you know, 9, 10. I wanted to spend my time with them. I'm super busy. There's no way you can lock me up. I know that there's really only one way usually off the opioids and all that. So, you know, I decided to, when my spine fused, I decided that was 2004, 5 years into the opiates, that I'd spend most of the time with the kids and doing things with them instead of working. So, because I'm actually planning on dying early, right? And 2011 came along. I'd been 11 years, 12 years on the opiates, and I'm up very high. I fell, broke my neck. They put me in the halo, and that released my neck muscles for the first time. And I went way down on the opiates, back to like 20 milligrams every 8 hours of oxycodone. And I was able to get my brain back in that time as well. And so I managed to fall, break my neck. That allowed me to go way down on my narcotics, which got me better and got me more active again. But it was basically starting the same thing over again, right? So all I did, once the halo came off, the pain was back, all my conditions are back, and I'm now on the same battle for the 10 years. You know, I couldn't have done it without them and my pain specialists and knowing the medication. I know it inside out. I've had to live on it for 21 years. You know, I put in here, you can take it for 10, 20 years and not become addicted, or 2 weeks and get addicted. It's all in how the pill's taken, living in pain and not out of pain, what the patient's goals are for life. And so the relationship with your family doctor has to become, I guess, very close. Since 2000, and we'll go 2000, basically I've seen my family doctor every week or 2 weeks. That started, I had pituitary failure, so I have to have testosterone shots every 2 weeks. I have to have B12s monthly. Currently, I think I'm 13 medications, 20 some diagnosed conditions. It's, you know, I'm a mess. And my family doctor has been with me throughout the whole thing to help me manage it. But the patient has to be very committed to using these things properly. Otherwise, they're very dangerous for the reasons you all know. And then, of course, the worst thing is the street supply of drugs. So anyway, had to try and throw this in all too quickly. If there's any questions, I'll take them.
Thank you so much, Ryan, for sharing your experience and bringing these up. We truly appreciate it. We do have time for a couple of questions. Jessica, I don't know if you're still on a line. I saw that you had a question, and I bet you it's one that's on a lot of people's minds. Would you care to unmute and ask Ryan directly?
Sure. Ryan, thank you so much for your time. It's always such a pleasure to have a patient perspective. I think we spend far too much time talking about things amongst ourselves and not bringing patients in. I loved how you stressed the importance of discussing mental health in the diagnosis of chronic pain. And I was just wondering if, as a patient, you feel there'd be any way that your doctor could have approached this with you that didn't turn it around. Patients will often say, "You think it's all in my head." And I think, no, I don't think it's all in your head. I think it's in your body, but you feel it in your head too. If you're not quite ready to entertain that your mental health may be a part of it, how could a doctor help get you there?
That's a really hard one, because that's admitting you have mental health problems, which is almost impossible for most human beings, right? And so that's a hard one. More on, I guess, you know, it's with all your complications that you have, say, as a patient, you can't tell when the mental health, say, depression, things might be starting. And so these type of medications aren't going to harm you. And so if you just be willing to give it a try, you might find that it helps. But you don't have to stay on it. If it doesn't work, you know, we'll take it off, we'll try another one, whichever, and try and find something that helps get you a little bit better. But you don't need to worry that this is going to be bad for you. Does that help?
Thank you. Yeah, thank you very much.
Thank you so much, Ryan. You know, we've got a couple of minutes left before it's 8:30. If anyone else has a question for Ryan, please feel free to unmute and ask it. I will just point to our evaluation survey I've got up on the screen, as well as the attendance screen. These links will both be sent to you via email if you can't get to them this morning. But again, we do value that time for evaluation. Any last minute comments or a question for Ryan?
Ryan, thank you so much for your story. And I think those 3 points I'll keep in the back of my mind for all of my my patients. And I think your description of the stigma for those of us who are working in Emerge is well taken. And we can't thank you enough for coming forth with the patient experience, because I think it's so valuable.
Yeah, at some point, like these are hard in 10 minutes, but at some point I'd like to sometime tell you all the whole thing, because 40 years of a chronic pain story that I experienced is bizarre. So
we'll take you up on that. Thank you.
Excellent. Okay, thank you so much. Anyways, virtual collaboration forums, we want them to be impactful. We want them to be of value to our members. So if you have any suggestions, please put them in the evaluation survey. Thank you again to our scientific planning committee. I saw Lara Nixon was on the call. We have Ryan, we have Monty, we have Rachel. I think we have Carrie and Dino, who have also joined the steering committee. We had Lucas, who is joining the steering committee. I just wanted to give a big shout out to a lot of our CNM members who have joined and taken on additional roles that are helping and committed to finding out ways that we can improve education we're able to provide within the CMN. We're always an open book, whether you want to talk to me, whether you want to talk to Kathy, shoot us an email. We definitely want to hear what you guys want. So again, thank you for attending this morning. We'll make sure we get this recording done. We'll make sure we get the slides posted and accessed by everyone. If you have any questions that we can follow up on, we're happy to reach out to the speakers and get some more information. You can always email us at mentorship@acfp.ca. And that's it for this morning. Thank you and have a great day.